Cancer. What is it? It's a group of disorders characterized by abnormal cell production, in which cells ignore growth regulating signals in the surrounding environment. Cancer is a disease that can affect any organ system. Despite the advances in research and technology, cancer continues to be the second leading cause of death in the United States. Metastasis. What is it? It's when abnormal cells invade the surrounding tissue and gain access to the lymph and blood vessels, carrying them to other areas of the body, causing the disease to spread. Malignant cancer cells versus benign cancer cells. Malignant cancer cells are cells or processes that have characteristics of cancer, and benign cancer cells are cells that are not cancerous. The malignant process, or spreading of the cells, happens when the genetically altered cells clone and multiply abnormally. Genetic mutations can be inherited or acquired. Once those abnormal cells have multiplied, they begin to invade the normal cellular process, affecting a client's immune system. The abnormalities in cellular process lead to cancer development, which ultimately leads to metastasis. So you might be asking yourself, what are some characteristics? How do I know if this is a benign cancer malignancy or this is a malignant neoplasm? So benign or non-cancerous cells and malignant or cancerous cells have many different characteristics, such as cell characteristics itself are different. The rate and the mode of which the growth happens is different. Their ability to metastasize is different. Their ability and what damage they do to tissue destruction is different. The ability to cause death is different. Please refer to the table in your book 12-1 as well as 12-2. Carcinogens and malignant transformation. A carcinogen is an agent that initiates or encourages the development of cancer cells. A complete carcinogen, such as cigarette smoking, is an agent that both initiates and encourages the development of cancer cells. There's a three-step process that involves the initiation phase, the promotion phase, and the progression phase. During the initiation phase, the carcinogen causes the mutation in the DNA. This can usually be reversed by a DNA repair mechanism or changes that activate the apoptosis, also known as cellular death. During the promotion phase, repeated exposure to co-carcinogens causes expansion of the initiated cells. Promotion is reversible if the promoting substance is removed. This is a key driver for cancer prevention. The third phase is the progression phase. During this phase, the altered cells have malignant behaviors, allowing angiogenesis or growth of new blood vessels to grow, which in turn allows the cancer to spread to surrounding tissues and continue to metastasize. Carcinogenic agents and factors. Note that the risk of cancer is multifactorial and is believed to be most commonly an interaction between the genetic makeup of the individual as well as environmental factors. Your book does a really good job of breaking down the differences. Some examples of viral might be HPV, Epstein-Barr virus, hepatitis B virus. There is little support to link bacterial infections to cancer development. However, secondary responses to bacterial infections may be linked to cancer development. Some physical agents such as sunlight exposure, excessive exposure to UV rays increases the risk of skin cancer. Those with fair skin still remain the highest risk. Cancer is a genetic gene, and some of the mutated genes are inherited. Please refer to table 12-1 for more specific details. As the nurse, what do we do here? This is why it's imperative to collect family history for both maternal and paternal sides. When you're doing an assessment on family history, clustered cancer is a red flag at a young age. Histories should go back at least 3 generations. When completing your patient assessment, physical findings such as polyps, as well as maybe lifestyle factors such as smoking that may predispose the client to cancer are very important. It's also important to ask the patient what they do for a living or what they did before they retired. Did they work in a nuclear lab? Were they a radiology technician? Were they exposed to frequent radiation? Frequent exposure to radiation increases the risk of cancer. This is why it's important to know how many images your client may have had previously. Some providers may delay a second or third CAT scan and order a less invasive test such as an ultrasound first to limit the exposure of radiation. The good thing is equipment today has improved to limit the amount of exposure, but those are high functioning jobs where it increases your exposure. Prevention. Why is early detection and prevention so important? First, it reduces cost. It limits resources needed for the care plan for the client, and it decreases mortality in those with advanced diseases. So primary prevention, what is it? It reduces the risk of disease through health promotion and the risk reduction strategies, including nutrition and exercise. An example of primary prevention is administering vaccines to reduce the risk, such as the HPV vaccine, which is given to help reduce the risk of cervical cancer, or as recommended by the CDC, the hepatitis B vaccine, which reduces the risk of liver cancer. Secondary prevention, which is the screening process and early detection. So early detection activities that try to identify precancerous lesions and early stage cancer in individuals who lack signs and symptoms of cancer. This includes community-based screening and detection programs. A lot of nurses will work these outreach programs specifically targeting low-income, low-educated communities, as they are more likely not to seek help preventatively. Then you have the tertiary prevention. This is when efforts focus on monitoring and for preventing reoccurrence of the primary cancer, as well as screening for development of secondary malignancies such as lymphoma or leukemia, which have been linked to certain chemo and radiation agents. Other survivors may also develop secondary malignancies related to inherited genes, lifestyle choices, and/or environmental exposures. So what can the nurse do? The nurse can educate. Educate on healthy lifestyles, such as increasing physical activity and doing it regularly, increasing their intake of whole grains, fruits, and vegetables, limiting their intake of alcohol, not smoking, or using other non-tobacco products. It's important to note that all nursing health assessments should incorporate assessment of cancer risks, and nursing care plans should address health education to help reduce those risks and promote appropriate screenings for these patients. The diagnosis of cancer. How is cancer diagnosed? Well, first, a full health history will be completed. Imaging is ordered to determine the presence and extent of the tumor, as well as to identify possible metastasis to surrounding organs, tissues, or bones. This might be done by a CAT scan, an MRI, a PET scan. Then we evaluate the function of the involved and uninvolved body systems and organs. This is done by obtaining blood, urine, or other body fluid specimens and sent to the lab. And then lastly, we obtain tissue and cell for analysis, right? This is an evaluation which includes the evaluation of the tumor, the stage, the grade, also known as a biopsy. Please refer to Table 12-4 for a full list of imaging that can be completed for diagnostic purposes. So you might be asking yourself, what does the RN do? What's the role here? Your patient receives a cancer diagnosis. The biggest thing to do here is listen, be supportive, and educate. Educate on the tests that might be performed. Let them know the expectations of them, such as positioning maybe, or their NPO status, or pre-medications, etc. Also, making sure to encourage the patient and family to express their feelings, bring questions forward, and be comfortable talking to their healthcare team. Tumor staging and grading. Staging determines the size of the tumor, the existence of local invasion, lymph node involvement, and distant metastasis. There are several different systems used to classify the severity of the disease. The most common being the TNM, tumor, nodes, metastasis. T, used to describe the size of the tumor and any spread to surrounding tissue. N, describing the spread into surrounding lymph nodes. And M, describing metastasis to other parts of the body. This is common language for the oncologist to determine the best course of treatment as well as the prognosis. Grading is done by taking a sample of cells that are used from tissue, surgical scrapings, or body fluids, to name a few, and determine the grade of the tumor, which goes from a stage 1 to a stage 4, 1 being less invasive with a better prognosis, and 4 being more invasive, less likely to respond to treatment, and having a much more poorer prognosis. Management of cancer. Treatment options that are offered depend on specifics of the disease, such as the stage, the type, and the grade. Treatment options can range from curing the disease to controlling the disease to palliative care. To cure the disease, this would include surgery to completely remove the cancer. For example, a patient who is diagnosed with localized breast cancer that decides to have a double mastectomy. To control the disease, which involves containing the tumor and decreasing the growth of the cells to prolong your life. And then there's palliative care, which is when the patient decides on no treatment for the disease process, however, decides on management of symptoms. Please note it's important for the patient and family to completely understand the treatment options and the goals of treatment. Surgical treatments of cancer. Diagnostic surgery. Diagnostic surgeries are completed by obtaining tissue from the tumor itself or surrounding lymph nodes to determine if it has spread or not. The type of biopsy is determined by the size and location of the tumor. There's 3 different kinds. Tumor removal, local excision, is generally done as an outpatient and used in smaller masses, whereas a wide excision, or you may hear it referred to as a radical excision, is removing the entire tumor or as much as possible, the surrounding lymph nodes, as well as any surrounding tissue that may be at risk. This is more of an in-depth procedure. This may alter the patient's appearance. As far as nursing management goes, this is where you're really going to have to be supportive. A lot of times patients may not want to look at their surgical site right in the beginning, and that's okay. Gradually increasing their involvement in their care is the best way to handle that. We have prophylactic surgery, which is done to remove tissue or organs that pose a risk for developing the disease, such as a family history of breast cancer, patient tests positive for the BRCA gene, maybe she decides to have a double mastectomy prophylactically. Palliative surgery, which is done to help improve the patient's quality of life and improve symptoms. It's important to note that this is not to be given the patient or family false hope that maybe they're removing the cancer. This is to just treat and improve the quality of life, treat symptoms. Reconstructive surgery, which is done for breast, head, neck, and skin cancer. And then there's different surgical techniques. Please refer to table 12-5 in your reading. Radiation therapy. Nearly 60% of patients diagnosed with cancer receive radiation in a course of treatment. Radiation can be used to cure the disease or control the tumor when it can't be removed surgically. It can also be used with or without chemotherapy to help reduce the size of the tumor. We may also see palliative radiation therapy used, which is a form to help relieve symptoms to improve the quality of life. This can be seen when the cancer has metastasized to brain, bone, or spinal cord. It's important to make sure that the patient as well as the family understand that this is just that, a palliative form to help relieve symptoms. This is not a cure. There are also external radiation as well as internal radiation. External, just like it sounds, it's the most common form that's used, and it's where there's a laser beam with high energy that's used externally from multiple different angles to try to lyse the tumor. Internal radiation is one that's the placement of the radiation is directly into the tumor or as close as possible to deliver high quality frequency of radiation. These can be in forms of noodles, seeds, beads, rods. These can be placed in multiple different body cavities, such as the vagina, in the breast, prostate. Radiation toxicity is a complication that can occur and is usually localized to the surrounding area. This happens within the first 2 weeks generally of the initial treatment. Nursing management of the patient undergoing radiation therapy. So working collaboratively with other members of the client's healthcare team, nurses really work on promoting healing and comfort to increase the quality of life. As the nurse, it's important to know certain risk factors that may predispose a patient to radiation toxicity, such as age, dose of radiation, nutritional status. Nurses will assess the patient's skin and status and overall well-being throughout the course of the radiation and treat symptomatically as needed. So how do we care for a patient receiving radiation? Please note that patients undergoing external radiation therapy are not quote-unquote radioactive, but internal radiation requires specific precautions, okay? So, it's important to note that when the implanted device is, when the device is implanted, it releases radiation while it's in the place. So we protect caregivers with proper shielding, limiting time with direct patient care, as well as keeping a distance, right? Radiology will give specific instructions on what to wear and guidance to follow. It's also important to make sure that patients who have undergone radiation therapy have proper signage on their doors, alerting people, limiting visitors to 30 minutes at a time, and maintaining a 6-foot distance between them and the patient. No young children or pregnant women should be in contact with them. And staff also wear special badges that will tell the amount and monitor how much radiation they were actually exposed to. Pregnant nurses should not care for these patients. Chemotherapy. So it's an agent that's used in an attempt to destroy cancer cells and prevent them from interfering with cellular function and replication. It's used primarily when trying to treat systematically rather than localized tumors that may respond well to radiation or surgical intervention. Chemo can be used in conjunction with surgery, whether it's pre-op or post-operatively, and or radiation therapy to reduce the size of the tumor. Now, whether the goal is to cure the cancer, contain it, or to treat palliatively to increase the quality of care, the goal of treatment has to be realistic so the correct formula can be prescribed. Eradication of 100% of the tumor is nearly impossible, but the goal of chemotherapy is to eliminate enough of the tumor so that the immune system can destroy the remaining metastatic cells on its own. There's a really short video that's pretty good in your book on page 319 of Brunner, if you can please refer to the short video on the cell cycle. Chemo administration. Chemo can be given in the hospital, in an outpatient setting, or even at home depending on the dose, the route, and the extent of the malignancy. Standards for safe administration of chemo have been developed by the Oncology Nursing Society and the American Society of Clinical Oncology. Dosing is designed to kill cancer cells while minimally affecting healthy tissue. So the dose is determined by a few factors such as the patient's body surface area, their weight, any previous exposure and or response that they may have had to chemo in the past. There can be standard dosing and sometimes dosing outside of the standardized treatment. It's important to note that some chemo agents do have a lifetime max dose on them. Extravasation is when the chemo is given intravenously and it leaks out of the vein into the surrounding tissue. So like your infiltration of your IVs, right? So this is when, depending on the agent, this can cause some mild irritation, such as just some localized redness and swelling, or this can be as damaging as causing tissue necrosis, sometimes requiring skin grafts. Just like any medication, hypersensitivity reactions can occur with chemo. They can occur within the 5 minutes of the infusion or up to 6 hours. There have been known to be some delayed reactions that can occur post-infusion. And unlike most medications, the patient might do fine the first time, maybe even the second time, but maybe the subsequent infusions they have a reaction to. Hypersensitivity reactions have been linked to life-threatening outcomes. Nursing management for a patient undergoing chemotherapy is going to be important. Patients are going to respond to chemo in a variety of ways. It's important for the nurse to have an ongoing assessment for their patient and treat accordingly. Patients may have limited to no appetite, vomiting, and diarrhea. So to have an ongoing assessment of their fluid and electrolyte status is going to be important. Assessing their cognitive status pre-treatment and post-treatment and letting family know that, there are things that may change there. Modifying some risks for infection and bleeding, education, right? Things that they may need to change. Administering chemotherapy, it's an important role of the nurse. Preventing nausea and vomiting, administering those antiemetics pre-treatment if that's what's going to help them. Managing their fatigue, protecting caregivers. A lot of patient and family education is going to go into this. Please refer to charts 12-4 and 12-5. Hemopoietic stem cell transplant, also known as HSCT, has been used for several years to treat malignant and non-malignant diseases. Most commonly, you'll see this used to treat hemolytic diseases such as non-Hodgkin's lymphoma or acute leukemia. Harvesting of the stem cells has definitely advanced from the days of having a donor go into the OR under anesthesia, where the bone marrow tissue is retrieved, to present day, where a majority can be retrieved from a peripheral site, processed, and then reinfused into the patient. You may also see stem cells that are harvested from cord blood at birth and stored to use at a later time. There are different types of HSCT. Please review them in your book on page 326. So nursing management in HSCT. So nursing plays a major role in the entire treatment of the transplant, right? Pre-transplant, nurses are obtaining lab work. They complete nutritional assessments, psychosocial assessments, which will be ongoing for post-transplant as well. Information regarding financing and support system is evaluated. Consent is generally obtained during this pre-transplant period. During the entire process, patient and family education is ongoing. So providing care during the treatment, right? During the treatment, nursing is completely treating symptomatic, is doing complete symptomatic treatment. So maybe you're administering those antiemetics for the nausea, you're monitoring for signs of symptoms of infection or hemorrhage. The education, again, is ongoing. You're monitoring their vital signs, trending them, monitoring for signs and symptoms of a reaction. And then post-transplant, patients remain at risk for infection. Until the new engraftment is well established, the patient remains at high risk for bleeding. So it's not uncommon for you to see these patients be supported with blood products. This, you may expect that the patient's going to be on reverse isolation to protect them, right? Maybe they're on a neutropenic diet, no fresh fruits, no vegetables. Maybe, they can have canned or frozen vegetables, some cooked pasta, rice, canned meat. They're also at risk for tumor lysis syndrome and acute tubular necrosis, are potential complications. If this transplant fails, donors sometimes experience a sense of guilt and other mood alterations. So we focus really on caring for the recipient, but we also need to remember that we have to care for the donor as well. So we're assessing them pre-transplant as well. We're assessing them, it's ongoing, right? Their ongoing assessment. Making sure that their education is ongoing. The support is needed for both the donor and the recipient, and sometimes I think we get wrapped up in that and forget about the donor. If the treatment has failed, it's not uncommon for donors to feel a sense of guilt. So making sure that that support system is still there for them pre, intra, and post-transplant. Graft versus host disease. Who's at highest risk? This is the leading cause of morbidity and mortality in the allogenic transplant population. So those who receive stem cells from a donor, right? Make sure we know the terminology. That was mentioned on the previous slide. So what happens and when? So this occurs when the donor lymphocytes initiate an immune response against the recipient's tissue. So this can be in the skin, the GI tract, the liver. It's during the beginning of the engraftment phase. What can we do to prevent it? Generally, patients will be given immune suppressant drugs such as cyclosporin, and this does help prevent GVHD. When can it happen? Well, it can be within the first 100 days, which they consider the acute phase, or this can be occurring after 100 days, which is considered a chronic phase. Immunotherapy, what is it used for? Immunotherapy is when medications or biochemical mediators are used to basically kill cancer cells. There's different types of immunotherapy. Non-specific immunotherapy really boosts the immune system to enhance cancer cell destruction. This is used in conjunction with chemo and or radiation therapy sometimes. There's monoclonal antibodies, which are used to grow and produce targeted antibodies for specific diseases. We have checkpoint inhibitors, cancer vaccines, such as the HPV vaccine, which we give in a preventative mechanism to help prevent cervical cancer, and then your T-cell immunotherapy. So targeted therapy, what is it? When is it used? And what is the nursing management behind it? So it's used to help kill or prevent the spread of cancer cells by targeting a specific part of the cell. We use this because there's less negative effects on the healthy cells than we see with conventional therapy. It allows for personalization of cancer therapy. There's a lot that goes on behind the scenes to make sure the patient's a candidate for it, and that's why each patient receives a personalization, because each dose may be a little bit different in targeting that specific cancer cell. Nursing management, there's a table on 12-8 that I want you to take a look at, but really the basics: patient education, standards of care for anti-cancer treatment patients, promoting self-care. We want to make sure that these patients are doing as much as they can in keeping their independence. Nursing care of patients with cancer. So what do we want to worry about with these patients? We want to think about skin integrity, stomatitis, which can affect their nutritional intake. Maybe they have some skin impairment or skin integrity issues related to radiation. Maybe they have some alopecia, some malignant skin lesions. Take a peek at the chart on 12-6. We want to make sure we're promoting nutrition for these patients, right? A lot of times they're nutritionally impaired. They have cancer-related anorexia, malabsorption issues. They have nausea and vomiting, not able to keep anything down. Pain control is a huge driver for these patients. They're very uncomfortable. Making sure and reassessing that this pain regimen we have them on is conducive to what they need. And also educating them on other alternatives that may help relieve some of their pain and discomfort. Decreasing fatigue. Are they anxious? Are their electrolytes off due to their nausea and vomiting, diarrhea? Making sure that we're monitoring those things. And sex. Sex is generally a topic that most people don't want to discuss. However, using the holistic approach in patient care, it's important to discuss how the patient feels, what their fears are. Maybe they had cancer of a reproductive organ, which left them infertile. Or maybe they have limited hormones and a decreased sex drive. So allowing them that opportunity to talk freely about a topic that they may be uncomfortable with or don't really want to bring up to somebody. Assessing their sleep pattern, right? Seeing how they're sleeping and what we might be able to do to help that. Take a look at page 337 for some really good nursing diagnosis and examples for patient care with cancer patients. Okay, let's talk about monitoring and managing potential complications with cancer patients. First and foremost, let's talk about infection. Early detection and early intervention are key when it comes to infections with cancer patients. Infections can come from the urinary tract, the respiratory tract, the skin, really any source. Maybe they have a port or a PICC line. That's the source. Making sure that we track and trend your patient's vital signs as well as their WBCs and their ANC. As your ANC decreases, your risk for infection increases. This is when your patient's going to become neutropenic. This is when you'll see them on neutropenic precautions, neutropenic diets. This is when we wear PPE to protect our patients from any pathogens we may be carrying. It's imperative that we have great hand hygiene at this point, taking care of these patients. Septic shock. Has their infection progressed so far that they're now in septic shock? Are they now showing signs and symptoms of organ dysfunction? Sepsis and septic shock can be fatal. Early detection and early intervention have proven to decrease mortality and improve patient outcomes. Bleeding and thrombocytopenia. So bleeding, patients who are undergoing treatment for cancer generally do have a decrease in their platelet count. Rule of thumb is less than 100,000 really puts them at a higher risk for bleeding. Obviously, the lower the platelets go, the higher the risk for bleeding. Thrombocytopenia can result in a decrease in bone marrow and chemoradiation. Again, early detection and early intervention increase patient outcomes. So what can we do as the nurse? We can monitor for bruising, bleeding, assess for petechiae, as well as tracking and trending your platelet counts. Let's talk about hospice. So really having a comprehensive multidisciplinary approach to patient care here with terminal illness, including their families, is really beneficial. So you'll hear family meetings, palliative care may be involved, all disciplines from all the care team are involved in making this decision. Really the referral for hospice should really be done sooner than later, really in a timely fashion. This helps address any family questions or concerns. There's a lot of dynamics that come out when we talk end stage anything, right, in end of life. So this helps to eliminate a lot of questions. Patients are able to voice their wishes in front of their loved ones. That helps kind of put everything to bay. What does hospice really focus on? A lot of people think that you go to hospice and you're just going to die, right? They really focus on the quality of life. So what kind of quality of life are you going to have? Palliative care, treatment of symptomatic treatment, their psychosocial and their spiritual care. You also work with grief with the patient and grief with the family for once the loved one passes away. Hospice care can often be provided by the hospital. Inpatient hospice does happen. There's a lot of home programs, which a lot of patients request. And then you have other hospice programs through local communities.